about 14 years old. I had just started playing football for my high school right before my freshman year. And maybe a couple of weeks into the season, freshman year, I catch a pass during practice and it hurt my finger. I go to the doctor takes a look at it, he sends me out of the office that day with hydrocodone, Vicodin, and that meant nothing to me at the time. I had never smoked weed before, I had never drank alcohol, never any kind of drugs or substances at all prior to that. And so to me it was pain medication, that's what it was, like Advil or Tylenol, and I was supposed to take them every, I don't know, 4 to 6 hours. And I had a tally sheet though that I was supposed to mark down every time I took a pill. I would put a tally mark down. You know, and it's funny looking back that I did that. Like that's the kind of kid I was. So then you flash forward maybe a couple of days and my buddy mentioning to me, that stuff gets you high. And I remember that thought in my head of like, what, I don't know what that means. What is high? But you hear about it. I mean, I'm in high school now and you're starting to hear people smoking pot, drinking at parties, and I'm thinking to myself, I don't know what that means, but the way that his eyes lit up when he said you can get high, it was kind of like, okay, maybe I want to see what that means.
When I was born, Tylenol was a prescription drug. There's clearly been a paradigm shift in prescribing for pain, and instead of using innocuous substances such as Tylenol or Motrin, Toradol, we've now started using more potent drugs like Vicodin, like Percocet, OxyContin, Opana, Methadone. We're now prescribing stimulants, we're prescribing sedatives, and now we're prescribing sleep aids. All of this is resulting in an enormous increase in the incidence of abuse of prescription drugs, which is leading to death.
I started practicing family practice 30 years ago. If I wrote a prescription for a month's supply of opiates, I probably would have gotten a call from the pharmacist questioning me, why is that? Not unless the patient had cancer or was in hospice. That was the only reason why you wrote prescriptions for more than a week. But now it's very common to see people on high doses of opiates on a daily basis for years and years. And there's actually no real scientific evidence-based data to justify doing that.
Well, unfortunately, over the last 10 years, we've seen a very significant increase in the number of overdoses, and those are both recreational and suicide overdoses.
Somewhere along the line, we began writing prescriptions for these powerful medications, and at some time, the number 20 or the number 30 stuck. I cannot think of any particular indication or reason why those numbers were chosen. As a matter of fact, most individuals who present with a painful condition usually only require a couple of days of medication.
If you're using higher doses of opiates to try to catch up to the pain, after about a few months, you start creating more problems than helping. You're starting to do some harm. There's more side effects than benefits. And actually, you can actually create pain. I'm an addiction doctor now, and I run an inpatient clinic, and one of the things I see every day is I get people off their opiates and the pain goes away. Opiate-induced hyperalgesia.
Well, over the last several years, we've seen a trend that has been occurring in our emergency rooms where we see an increasing number of young individuals, teenagers and young adults who are coming in with various types of overdoses.
We're losing patients at 1 every 19 minutes. In the last 2 years, we lost almost 80,000 patients to narcotic overdose-related deaths.
And one of the other disturbing trends is the number of individuals who come in with unknown overdoses because they're simply taking their parents' medications without having any real understanding of their significance and their potential hazard.
As a physician, it is our responsibility and our duty to not only be aware of the problem, but be very conscientious when we prescribe these narcotics. I think our teens and our community deserve it.
We're taught in the hospital that controlling pain is very important. In fact, it's kind of pounded into our heads. We have to do scoring and make sure that the pain medication is given in a timely manner and that the pain medication works. So we've kind of been trained to almost overreact to pain. And I think that that approach extends itself into the home, where when patients going home from the hospital, we kind of still have that same mindset that, we want to make sure that they are comfortable at home and that they have good pain relief at home. And I think we sometimes are generous with the pain medication for that reason, not maybe realizing that, we can do harm.
I think it's also important for physicians to really think about these medications when they're prescribing them, and really taking into account what the necessary amount of pills is, and not prescribing any extras.
Be careful of those patients that are returning. Be aware that they are going to other physicians. Be aware that they're being seen at other hospitals.
Patient walks in my office today, she gets a prescription for a medication. She may see an urgent care that's literally below my office and get the same medication. And when she sees me back in a month, if there hasn't been any collaboration between me and any other provider for that specific patient, she may have gotten medications from 6, 7, 8 different providers.
I have my little tally sheet, and I'm going to take my pill, and I put the pill in my hand, and I pause for that minute, and I think of my buddy saying, you can get high on this stuff. Or I go from this kid who is listening to his mom writing tally marks down for some medication, I don't know why, but I'm just trusting my mom like a kid does, to all of a sudden saying, no, I'm going to trust what my buddy just said. And I saved up 4 or 5 of them, and that next night, I took them all. And that was, I would say, the next defining moment, that first high.
75% of those pills that you're writing for are probably going to go to something other than what you're writing it for, and other than pain. It's going to be used for something else that's not medical. And we have to start thinking about, how much are we giving somebody, and why can't we do something else, other alternatives. Adolescent brains are wired differently, and their prefrontal cortex is not functioning, their executive commission are part of their brain, their judgment center isn't working, and you give them opiates, it's different than giving somebody that's 40 years old an opiate. So adolescents really have to be carefully watched, and at all costs try to use something besides an opiate. My treatment center is 18 years old and over. 90% of my patients started before they were 18. They were exposed to prescription opiates, and it led to more and more.
Well, prescription and over-the-counter drug abuse is the fastest growing drug problem in the United States. And it's critical that we address this problem, because studies have shown that teens under the age of 16 that have had issues with prescription drug abuse will have a 40% higher chance of having drug dependency issues later in life.
I'm high now for the first time in my life. I understand that light in this kid's eyes when he's telling me, you can get high on this stuff. And that to me, that's the pivotal moment in my life, where it's that term of chasing the dragon. And I, time and time again, for the next 7 years of my life, would look back to that moment and wonder when that's going to happen again. Because it didn't happen ever again. I never felt like that ever again. And I spent every waking moment from 14 to almost 21 looking for that exact same feeling, and it just never came back.
Starting a child on narcotics means sensitizing them, their brains, their chemistry to that medication for the rest of their life. Understand that there is a pharmacologically predictable tolerance and dependence to any narcotic taken for any longer than 4 weeks.
So it goes from that, now I'm snorting oxy, in addition to whatever else I can get, and it turns into this feeding frenzy of, hey, who's got this? Hey, you have some Xanax, let me have some, I'll snort the Xanax, I don't care.
They feel like because these prescription drugs are legal, that they should be safe. They're prescribed to them by a doctor, so they should be safe. And sometimes they decide, they make one single mistake, and they decide to take more than their allotted dose, and with catastrophic effects.
And I really consciously think about, okay, how many pain pills is a patient going to take every day? So they should only take 3 or 4 pain pills a day. And they really should only have severe pain for 2 or 3, 4 days. That only gives you, 10 or 15 pills total. You shouldn't need a prescription for 50 or 100 pills.
So we decided to first do an audit of the pill counts. We found it to be absolutely crazy. Kids that were taking Tylenol were going home with 50, 70 Vicodins. No reason for that. So we decided to implement a full education program in all the departments. All the physicians and all the nurse practitioners and physician assistants were educated They were given surveys, and they were given a sheet with a pill count on top of the patient's chart, so they were aware of what the actual pain medication need was prior to prescribing these drugs. We've had great success. We've had over 50% decrease in pill count, and we feel like we're making a small but very, very important difference in our community, reducing the amount of pills that are out there. We also have an education sheet, and every parent and every patient that is going home with a narcotic gets, that talks about locking up the medications, talks about the proper way of disposing of the medication, and the importance of seeing this as a potentially harmful thing.
I think we see the recreational users on the weekends where they'll go to a party and they'll have basically a punch bowl full of pills that people have scavenged from typically from their parents, put them in the bowl, and then take a few.
These drugs are easy to find, and a lot of times they're free. 70% of kids tell us they found their drugs from medicine cabinets in their friends, family, and even their own homes. So the problem is twofold. We have increased access to these drugs, and we also have very little education in our community, even amongst physicians.
And there's a genetic difference too. I think when you're writing prescriptions to somebody, you need to know their personal history and their family history. Does alcoholism run in their family? Do people drink too much in their family? Have they had a DUI or a car accident or something? There's a genetic part of our population, 15% of our population is set up to have an attraction to anything addictive. They're going to have like a potato chip effect. When they take one, they're going to want another one.
And now I've got this downward spiral that leads to me with a needle in my arm is where it led. Meth and heroin, because the drugs weren't cutting it.
They have to sign a contract saying they're going to get drug tested. One of the reasons why you want to do a drug test is actually see if it's negative. Because somebody's taking high doses of opiates and you're getting refills and they're negative, they're probably selling it.
It progresses to trying more and more of the pills, getting more and more of the prescriptions, learning what to say to my doctor that will get him to give me more and more of them.
Be careful. Patients that come to the hospital knowing what they want, asking for Dilaudid or Demerol or OxyContin. Be careful of first-time visits. Be careful of patients from out of state. Be careful with patients who don't have a picture ID. Be careful with low-income patients, as these drugs are very profitable on the street and a big source of income. Just be careful.
Unless it's you, or unless it's one of your colleagues, and you've been individually sued for $2 million, $3 million, $5 million, you've been investigated by the DEA, you've been called by the state coroner's office, unless those things have happened to you, you probably aren't aware that you're at risk.
I'm a junkie. I'm probably going to die too young. I'm going to do what I have to do to get it. I don't care who I hurt or what I take or what I steal, what crimes I break. None of that matters anymore.
And I encourage you to really, really think about the oath that you have taken or you're about to take, to do no harm, and really carefully think about these prescription medications that we are writing for every day that could potentially do very much harm.
And the sole purpose of why I am volunteering and participating in this project is because of the sheer escalation of deaths from prescription medications, which have also led to the use of heroin in our community.
This is the first time in history that we've ever had such a large proportion of our population on high doses of opiates on a daily basis. And it's creating new problems.
It is my individual responsibility to prevent patients from not only becoming dependent on medications, but from taking more than they're prescribed, getting them from multiple prescribers, and overdosing and dying on these medications. It's my individual responsibility.
I think the point of making this film is to really try to get back to how it was maybe 30 years ago. We did really well without a lot of opiates.
I don't want to say that, that my doctor knew the path I was going. I don't think he knew. I think it's the exact opposite. And I think he probably thought he was doing his job, giving someone in pain medication. It makes sense. But maybe try some other pain medications first.
My hope is that physicians are really aware of the magnitude of the problem, of the fact that we are a contributing factor to the problem, and the fact that we have the power to make a change.